There it is. And hand it over to Dr. Evans. Thanks for being here.
Hi, everybody. Thank you for joining us. Today we're talking about elective general surgery, what to expect, and how to optimize recovery. Obviously, this is a really broad topic. General surgery encompasses a lot of different areas. So I am sort of looking at this from a high level just to give you an introduction, and I'm happy to answer any questions that you have at the end. Before I fully get into it, one of the questions we always get is general surgery a specialty? Is that a specialized area? 100% yes, even though it's called general surgery is a 5-year program, and we really specialize in the core parts of the body, and we'll get into what that means soon. Okay, so first we're going to introduce elective surgery. We're going to go over most common operations that are performed by general surgeons, what the preoperative evaluation looks like, what prehabilitation is, and how to optimize the best outcome that you can get, what your expected recovery is, and then also just a summary at the end. All right, elective surgery. So when people hear that, they think, well, hey, I've got something really important. What do you mean it's elective? Elective just means that it's not, whatever problem you have is not immediately life-threatening. This includes hernias, gallbladder disease, and even cancer. So yes, these things do need to be treated. It's not like it's an optional thing to treat a lot of the time. They may either be affecting your activities of daily living, affecting your ability to do your job, or when we're looking at things like cancer or precancerous lesions, this is important to your survival. So yes, it absolutely needs to be done, but it's still coded as an elective procedure by the insurance companies because it doesn't have to necessarily be done that very day. It means that we have time to schedule, time to plan, time to discuss, and also time to get you optimized to make sure that you get the best outcome possible. All right, what are some of the most common elective operations that we do as general surgeons? So cholecystectomy, that means removing the gallbladder. That can be done laparoscopically or robotically. A long time ago, it used to be done open. It's very rare that we do it that way now. 1% or less of the time we do these open. Hernia repairs can be done either robotic or open, and this is a huge area, right? So hernias can include inguinal or groin hernias, umbilical hernias, which are commonly known as a belly button hernia, a ventral hernia, which is a hernia on the abdominal wall, or even what's called a hiatal hernia, which is where the stomach moves up into the chest cavity. Those are a very broad area. And again, those can be done robotically or open, and also sometimes laparoscopically. Here, we tend to either choose the robotic or the open approach. Breast surgery, this is a big part, roughly 20-25% of what we see. We do this for cancer, benign disease. Benign disease means anything that's not cancerous. And then also prophylactically. So whenever someone has a genetic mutation, such as BRCA1 or BRCA2, we will offer a prophylactic surgery to prevent that patient from getting cancer, since we know that they are higher risk of cancer throughout their lifetime. Another area that we see a lot is colon surgery. This can be for cancer, precancerous lesions as well, or for diverticulitis. These are the most common reasons that we do this type of operation. And when we talk about this, we're usually removing a segment of the colon and then putting everything back together. This does require a much longer stay. It's a bigger operation, and definitely an area where we really want to focus on that prehabilitation portion. Finally, we also treat skin cancers. So that can be melanoma, basal cell, or squamous cell. Those are the most common types that we see. Some of those are done in the office. They're small procedures, and sometimes they're done in the operating room. It really just depends on the size of the lesion and whether or not we're doing a lymph node sampling. Okay, so now we're going to talk about what are the different approaches and why do we do them. And again, this is very broad because we're talking about all the different types of operations, but really it does hold. So for ease and technicality, open surgery used to be thought of as the easiest. It is definitely the oldest. I personally believe once you're doing a lot of robotic surgery or a lot of laparoscopic surgery, sometimes things are actually easier with a robot than they are even open, because we do have better visualization and we have sort of a zoomed in view and all these different techniques, and we have all these really cool things that we can use in the OR that sometimes actually make that approach easier. Laparoscopic, and when we say that it's not the easiest, it's because it requires a lot of extra training and time to really learn how to do that more advanced approach. Laparoscopic is considered to be medium in terms of ease and technicality, and then robotic is definitely newest, and there is a learning curve. Once you're past that learning curve, though, again, sometimes those cases actually can be easier with that minimally invasive technique. In terms of pain, open surgery, most common is associated with the highest amount of pain. Laparoscopic is less, and then robotic tends to be the least. So we do see really good outcomes in terms of decreased pain when we're looking at that robotic approach. Length of stay with open surgery is usually the longest. Laparoscopic can be in the middle, and then depending on the procedure with robotic cases, that can even be shorter than the laparoscopic approach. When it comes to recovery, you'll notice a trend. Open operations tend to have the longest recovery. Laparoscopic ones are shorter, and then the robotic approach tends to have the shortest recovery in terms of length of stay in the hospital, as well as time to getting back to your activities that you like to do. All right, so I'm sure you're asking at this point, what is the robot? We use the Da Vinci robot. It is the most common one used in the United States. It was also the first advanced robotic platform. Um, it was FDA approved in the year 2000. It's been available at Barton since 2012. When it was approved in 2000, there was not wide adoption. It was FDA approved, was only used at handful of centers around the country. Barton actually was early to adopt it, which was great. It was here when I got here. I was really happy that we had that as an option in terms of the types of tools we could use in the operating room. Since we got the original robot, we have actually upgraded to a new system called the XI. And that has a lot of advantages over the previous version in terms of ease of use, as well as just making it safer and better for the patient. It's important to know that when we use the robot, it is controlled by the surgeon at the console. It does not function on its own. This is not an AI procedure. We are 100% in charge of what's going on. And we actually use our hands to control it and then our feet as well. So it's a little bit like playing an organ. It gives us 3D vision, so we have excellent visualization. And we also have some techniques that we can use, which include what's called ICG, which can light up different organ structures and really help us identify what we need to see. Finally, it does have a wristed function, meaning that the instruments that we're using can move just like the human wrist. And it allows for much more delicate procedures than when we're doing it laparoscopically, because we do have that better range of motion. All right, so we're going to switch gears a little bit. We just went over kind of the whole broad range of different operations that we do, why we do them, what the different approaches are. Now we're going to talk about that preoperative evaluation. This is one of the most important parts of the operation, is making sure that you and the surgeon are both a good fit. So first thing is you're going to meet them. You're going to decide, are they the right fit for you? Do you feel comfortable with your surgeon? Do you feel comfortable asking questions? And at the same time, they're going to meet you and really get to know your story and why you're seeing them. And things that we're asking when we first meet you are, how acute is this? Do you need an operation? Because sometimes patients, not uncommonly, will come to us, and yes, they could have surgery, but really they may benefit from other non-operative techniques first. And some patients, we really can get through whatever process they have without needing surgery. For the ones that do need surgery, we go over what it entails and what the risks are with the patient. And while we're doing that, we really need to know some important parts. Like, does the patient have heart or lung issues? Do they have kidney issues? Do we need to get a larger care team involved to make sure that they're safe for surgery? You can see on this left-hand side, it used to just really be the surgeon and the patient. Now there's a whole care team that's involved. We want to make sure that your primary care doctor is on board. We want to talk with internal medicine, cardiology, pulmonology, if needed beforehand. We involve the anesthesia team, and then also whomever your caregiver is. A lot of times we really we want patients to have their family or caregiver at the appointment with them when we meet them, because we want to make sure that they're going to have someone at home who understands the process and knows what they're going to be going through to prepare for that transition from the hospital back home, whether it's an outpatient operation or something that requires a longer length of stay. So we really want to make sure that you're successful when you get home. Um, Once we're finished with getting all that information in your history, we may have you undergo additional testing and preoperative risk assessment. The reason for this is we want to make sure that you're as successful as possible. And it's really important we get that whole multidisciplinary care team on board and that we optimize the best care you could possibly have. We're also going to go over if there are any enhanced recovery programs that may be important for you. For example, whenever we do a colon resection, we follow ERAS, which is an early recovery after surgery protocol. We have you do special things at home the day before surgeries that reduce the risk of infection and also reduce the time that it takes to have your intestines working again. Make sure that they're up and going as quickly as possible to prevent discomfort to get you home. All right, so what is prehabilitation? So I talked about that just a tiny bit. Prehabilitation really means getting you as fit as possible before the operation to help optimize your return to care and your return to normal activity after surgery. Instead of rehabilitation, we talk about prehabilitation. This is newer in the surgical literature than rehabilitation was. But we've really learned that by optimizing the preoperative care and the preoperative state of the patient, we can really improve the postoperative recovery period. There are 4 different areas to prehab or rehabilitation. We talk about the physical, social, medical, and mental aspects. From a physical side, there's very clear data that some of these different interventions can really improve your recovery. We want you to increase your physical activity. So if someone is sedentary, I tell them I want you to start walking, minimum 10 to 20 minutes a day. We try to get you out, up and about. If someone's already somewhat active, we try to get them a little bit more active. So if you can lift weights, if you're not limited against it, that can be really helpful. Increasing your cardiovascular activity is also helpful as well. In addition to that physical activity, we really want patients to increase their protein intake in the period before the operation. For an average patient, we talk about kilograms. So the average 70-kilogram patient, which is around 150, 155 pounds, we want those patients getting 100 grams of protein a day. If possible, we want that from a whey protein supplement, but I really don't care how you get it. That 100 grams is the most important part. Whey protein does have extra leucine in it, which is an amino acid that in elderly patients, those over 65, has been shown to increase muscle mass. So that's just something really important. We want to improve that muscle mass as much as possible right before surgery. That helps you heal your wounds without taking some of your muscle reserves from the rest of your body. So the stronger you are before surgery, the stronger you are going out. 2 ways to do that. You increase your physical activity and you increase that protein intake. Again, the goal here is a minimum of 100 grams per day of protein. Finally, for our obese patients, we do encourage weight loss when it's possible and if time allows. I'm going to give you an example of when that really matters. So for a ventral hernia, that's the type of hernia that we see on the abdominal wall. Patients that have a BMI over 30, BMI is body mass index. There's significant increased risk of wound infections and recurrence. When it goes above 35, that's even higher. We want you to come to surgery once. We don't want you to have to come back in 5 to 10 years if it's recurring. Getting your weight down can really help reduce the chances of that hernia coming back. We do have some really good tools in our toolkit now to help with that. So it's not just telling patients to eat better and exercise, because everyone's pretty much tried that by the time they've come to us anyways. So we really do work with the primary care team to try and get patients to a healthier weight before surgery, again, as long as there's time for that. And that's something that we will go through that process with you. So we usually will see patients every 1 to 2 months in follow-up to assess, see how they're doing, hold their hand, make sure that they're meeting the goals if possible, to really help get them to that ideal state before they go under for their operation. From a social standpoint, we really want patients to quit smoking and minimize alcohol consumption. And you'll hear this all the time, right? These lifestyle factors are really important that can help you overall with your health. They can also make a huge difference when it comes through getting through an operation and getting through anesthesia. For smoking, super important everyone knows this does include vaping and inhaled THC products. We talk to all of our patients about this. So inhaled marijuana, inhaled THC does affect the lungs, and it increases the risk of getting pneumonia after surgery, as well as other pulmonary problems from the operation. So we really want patients to stop vaping, stop inhaled THC, and stop smoking cigarettes. Again, we will help you with this. We're not just going to tell you to stop. We're happy to give you different resources. And that's something that when you're meeting with your surgeon, you really want to make sure that you talk to them about to try and help get you off of that smoking habit. Again, it helps with the lungs, reduces pneumonia. It also helps with wound healing. So nicotine containing products, tobacco products specifically, really do affect wound healing, increase the risk of poor wound healing, increase the risk of getting a wound infection. So that's super important. Minimizing alcohol consumption. In patients that drink a lot, we try to help them taper down. In patients that that are drinking a lot, it can affect their liver, it can affect their ability to heal their wounds. It also can interact with the pain medications that we use after the operation. All right, switching gears again, from a medical standpoint, here we're really looking at optimizing pre-existing conditions. So what does that mean? Let's say someone has sleep apnea where they're overnight waking up multiple times because they're not breathing properly. If that's not treated, it significantly increases the risk of perioperative complications. We do not want that happening. So we want to make sure that if a patient has sleep apnea, we want them on CPAP and we want them stabilized on their CPAP before we undergo an elective operation. We also really look at medical optimization of cardiac comorbidities. So let's say someone has heart failure. We want to make sure that they're on the right medications, that their heart is working as good as it possibly can be before the date of surgery. And we're also looking to make sure that there's nothing that is contraindication to us operating, because the last thing we want to do is bring someone to the operating room to fix a problem and then cause something in terms of a worsening heart condition. So we always really look at that, and you'll notice that when you go through the preoperative process, that the pre-anesthesia clinic, the pre-op anesthesia clinic is going to be working with you to make sure that we've checked all those boxes, checked everything that we can to make sure that you are optimized from a medical standpoint. The fourth branch of rehabilitation is the mental side. It's really important to learn ways to lower stress and anxiety. This is something that if you're having issues with stress or anxiety before surgery, make sure you talk to your surgeon. We want to help you establish coping mechanisms and a support system. Part of that is getting education from us and the rest of your care team regarding what the operation is, what it entails, and what to expect. When you go into surgery and you have a lot of questions, it's very easy for your mind to wander and to get into that stress cycle. When you know what you're expecting, when you know what you're going to see, that can help answer a lot of those questions and stop that cycle from ever starting. When we talk about coping mechanisms, there are a lot of things that we can do to help you. Some of them may sound silly, but they really do work. So yoga, meditation, focusing on sleep, all of those things are really important to help you get through this time and have the best outcome possible. All right, so what are the benefits of rehabilitation? We just went through this huge list of things to do, huge list of things that we're going to talk about. Why are we asking you to do this? Well, strength. So that's number one. The stronger you are going into the operation, the stronger you are going to be after. This is super important in our patients that are either malnourished, patients with cancer who potentially are frail from that, and then also patients who are 65 and above, because those patients are at much higher risk for losing muscle mass in the perioperative period. We want to make sure we do everything that we can to improve your strength, improve that muscle mass before the operation to maintain it so that you don't see a significant decline after the procedure or operation. Number two, rehabilitation can reduce pain after surgery. Increased physical activity actually preps your nervous system. So one of the things that it does is it gets your nerves accustomed to low levels of stress, to low levels of pain. Anyone who's ever been through a pretty rough workout, who's had that soreness, knows what it feels like. And that's your body recovering. Going through that process not only helps your muscles, but also helps the nerves and teaches those nerves what the difference is between severe pain and low levels of recovery type pain. You also get the endorphins from exercise, which help in so many ways that we don't even really know every single way that they work, but we know that those endorphins and that regular exercise really can cross over and help you in terms of recovery. There have been a lot of studies on this, so it's not just something telling you, it's not just word of mouth, it's not just anecdotal. There have been a lot of studies in the last 10 to 15 years that have shown there's decreased postoperative pain in patients that started an exercise regimen preoperatively. Now, I'm not going to tell someone who's wheelchair bound to get up and go to the gym and lift a whole bunch of weights. I'm not going to tell someone who's having difficulty with mobilization that they need to be at the level of an Olympic athlete. The goal is to do more than what you're doing currently. So we do have a lot of recommendations. We can even sometimes get you into physical therapy to help if needed, to help get you as strong as possible before the operation. Um, the third area, why are we doing this, is decreased recovery time. The better shape you're in, the faster you're going to go to get home. And we really do see this with our professional athletes. Their recovery time is so much shorter than your average 25, even or 30-year-old. And that's because their body is in such great shape. It's accustomed to healing. They've literally trained their cells, they've trained their muscles, they've trained their nerves to recover faster. And part of that is that exercise cycle where exercise does cause a small amount of injury to the tissue, the body repairs it, and then the body gets accustomed to repairing. We can take that information from those high level athletes and take it and apply it to everybody else by exercising, by getting in that activity that you weren't doing before. You're going to teach your body to recover faster. It's also going to help you return to normal activities quicker, and it's going to get you back to doing what you love to do. My goal is not just to have a successful operation. The goal is to have a successful operation and a patient who's back to doing what they want to do. So it's twofold, right? It's not just the day of surgery and that recovery. Post-operative expectations. So first thing that I would ask you to ask your surgeon, is this an inpatient or an outpatient procedure? Inpatient means that you're going to be spending the night in the hospital. It could be one night, it could be several nights. It's really important that you know what that estimated length of stay is so that you can get everything ready at home. Do you have pets? Do you have children? Do you need to arrange someone to help with things at your house? Whatever that is, we want to make sure that you know what to expect going in. For an outpatient operation, we do always make sure that you have someone driving you home, someone staying with you overnight after the operation, because we don't want you by yourself after having anesthesia. So something we want to make sure that you're prepared for. We also want to talk about things like, what does your house look like? Are you able to access it? Do you have to go up 2 flights of stairs? Will you be able to do that? Those are important things to discuss. Also important, whatever questions you have in terms of what type of job do you do? So if you sit at a desk and you're on a computer most of the time, your ability to go back to work is usually going to be faster than someone who's working construction and lifting heavy things on a regular basis. So very important that you talk with your surgeon about what your job is, what your job duties entail, so that you can anticipate how much time you're going to need to take off. Also, it's helpful to know, like, will you need help at home? Are you going to need help from everything that you're doing? Like, is someone going to need to bring you all of your food, bring you water, all of those things? Or do you just need help, like, shoveling snow? And that's the biggest question that we get, really, especially obviously in the winter here. That's a big one. Make sure you have someone that can help out with snow removal. Okay, finally, all right, what did we talk about today? We discussed what elective surgery is. We discussed the most common elective procedures that are performed by the general surgery department. We covered our preoperative assessment. We evaluated rehabilitation strategies, and we also touched on the post-op period, what to expect and how to improve that recovery as much as possible. All right, what questions do we have?
Great. Thank you so much. That was wonderful. We do have a couple of questions that have already come. Sorry about that. If you have one, please feel welcome to put it in the Q&A box. at the bottom of the screen or in the chat box. You can ask questions anonymously as well if you'd like. The first one is, did you mention hemorrhoids? Is that a common surgery? And if so, what would necessitate removal?
Yep, yeah, it's a great question. So we treat a lot of perianal disease, not we do treat hemorrhoids, but we treat other things as well. So a lot of times we will get referrals for hemorrhoids, but it may be other things like an anal fissure or a fistula, or sometimes even we can find cancerous lesions around the anus. So yes, we definitely treat them. We don't always recommend surgery. If it is truly hemorrhoids, a lot of times patients can get better by adjusting their bowel care regimen, making their stools softer, doing things called sitz baths, as well as topical medication. And we almost always almost always recommend those first. Hemorrhoids are graded from 1 to 4. 1 is the least severe, 4 is the most severe. If someone has significant bleeding or if they have grade 4 type hemorrhoids, then we usually will do surgery. We'll usually operate on those right away.
And the next one is about hernia repair. Can you just get into some detail about what that entails?
Yeah, sure, absolutely. So for hernia surgery, we really break it up into 2 categories. So there's the inguinal or groin hernias, and then there's the abdominal hernias, which we call ventral, and those include the umbilical and the epigastric. The groin hernias are the most common type of hernias that we see. We see those all the time. And they are more common in men than in women, but women actually get them a lot too. And as we see women participating in more lifting and more physical activity, we're seeing these more frequently in women than we used to. A groin hernia is the hernia that happens in men in the area sort of right where the site of your pubic bone is. And it can be very uncomfortable. In women, it's the same. It's not as obvious in women. So any woman that has intermittent groin pain, I really do recommend that they go see their primary care doctor to see if they have a hernia there. Um, Most of the time, groin hernias are not a life-threatening severe problem. They affect your daily living. They will affect your ability to potentially do your job as well as to do the things that you like to do. It is rare that the intestine will get stuck in an inguinal hernia. The majority of the time we are fixing these because they're preventing patients from participating in the activities that they like, not because it's an emergency. That part is very rare. When we fix them, it is an outpatient procedure. So you would come into the hospital. We would either do it via an open approach or a minimally invasive approach. The open approach has been around much longer. We do have more long-term data in terms of recurrence risk with the open approach, but there's significantly less pain with the minimally invasive approach, and patients do get back to their normal activities faster when we do it minimally invasively, and that's either robotically or laparoscopically. The majority of us now actually do them robotically more than the laparoscopic because we just have better visualization. That's sort of a summary of inguinal hernias. From a ventral hernia standpoint, these are higher risk, and that's the kind that's in your abdomen. Those are higher risk for the intestines getting incarcerated or strangulated. So the majority of the times we're facing those because they're both symptomatic and also to prevent a potential surgical emergency. With the ventral hernia operations, when they're small, patients go home the same day. If they're bigger, we will often keep patients overnight after the operation for pain control and to watch them and make sure that they're recovering appropriately.
Great. And this looks like it will be the last question. So again, if you have any other questions, feel free to put them in and I'll get there. But just wondering from an emergent perspective, what you most commonly see.
Yeah. So, really several different areas. So, we see a lot of patients that have appendicitis. That is one of the most common things that we do out of the emergency department. It's a great procedure because you will see, and it's one of my favorite things to do because I'll have a patient who's in a lot of pain, who's sick, Um, and it's a very easy procedure, honestly, compared to most of the other things that we do. And we can get rid of that source of pain and get rid of the thing that's making them sick. And patients will literally wake up and start feeling better. So that's one of the most common things that we do out of the emergency department. Um, we also will treat patients who have acute cholecystitis, and that's where the gallbladder is acutely inflamed and needs to be removed urgently. Um, and we see those very frequently. Additionally, we'll see patients that may have a bowel obstruction or problems with their colon, like diverticulitis, or other torsions and things like that that can happen with the bowel as well. In patients that have problems with their intestinal tract where they're going to the emergency department, they're more likely to have a bigger open operation, just due to the nature of the disease, and the need to kind of work throughout the abdomen. And those patients usually will be in the hospital a fair amount longer.
Great. Well, I think we covered everything. Unless, sorry, were you still going? I didn't mean
No, it's okay. Yeah. No, that's about everything. Yeah. We
to.
all do see
I
trauma.
think, yeah, I think appendicitis is something that, especially when you're a parent, you're always worried that every stomach ache could be that. So it's good to know we're in good hands if that comes up. But anyway, I just appreciate your time tonight, Dr. Evans, and for everyone attending. There will be an exit survey, so we'd love to get your feedback about how we did and topics you'd like to hear from us in the future. And like I said, if I didn't mention it, this has been recorded, so you can always refer back to it on our YouTube page, and our social media. So again, I hope everyone has a wonderful night, and thanks so much, Dr. Evans.
Bye.